Welcome and thank you for attending our Head of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Michelle Studnicki and I'm a project coordinator for the Cancer Institute. There are a few housekeeping items we need to review before we start. During the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants are not able to speak during the conference or during the conference, but again, we encourage feedback via the chat option. Tonight, we are excited to welcome Dr. James McCormick and Dr. Nathan Bahary, and our topic tonight is advances in colon cancer that could change your life. I just want to share a little bit of the biographies on Dr. McCormick and Dr. Bahary before we begin. Dr. James McCormick is a professor of surgery at Drexel University College of Medicine and a leading expert in colorectal surgery and inflammatory bowel disease. His clinical practice focuses on minimally invasive and robotic approaches to complex pelvic surgery, colon and rectal cancer, including recurrent disease and bowel reconstruction. He directs colorectal cancer care at the Allegheny Health Network's NAPRC Certified Rectal Cancer Center of Excellence. Dr. McCormick received his Doctor of Osteopathic Medicine from the Lake Erie College of Osteopathic Medicine, his general residency at Temple University at West Penn Hospital, including multiple teaching, research, and clinical performance awards, and his colon and rectal surgery residency at the University of Texas Southwestern Parkland Hospital. Dr. McCormick is a prolific researcher with over 90 peer-reviewed publications and significant experience in clinical trials, phases 1 to 3, device translational. He serves as a principal investigator on numerous studies, managing hundreds of thousands of dollars in research funding. His research interests include minimally invasive laparoscopic and transanal colorectal surgery, surgical robotics, multidisciplinary team management, and perioperative care. He is an American College of General Surgery Alliance certified surgeon and investigator. Dr. Nathan Bahary. Dr. Nathan Bahary is the Division Chief of Medical Oncology and the Director of Clinical Research at the Allegheny Health Network Cancer Institute. Board certified in clinical oncology, Dr. Bahary received his medical degree from Cornell University Medical College in New York, now the WOW, Cornell Medical College, and his PhD from the Rockefeller University in New York. He completed his residency at the Beth Israel Deaconess Medical Center in Boston and a research postdoctoral fellowship at Harvard Medical School in Boston. He is a member of the ECOG GI Committee and the NCI Pancreatic Task Force. Dr. Bahary's research interests include identifying novel genes and pathways underlying normal gastrointestinal development in cancer to both design rational molecular-based disease markers for early detection of gastrointestinal cancers, as well as rational directed therapies for their treatment. Dr. Bahary joined the Allegheny Health Network Cancer Institute in 2021 as the Division Chief of Medical Oncology and the Director of the Allegheny Health Network Cancer Institute's Clinical Trial Program. Welcome, Drs. Bahary and Dr. McCormick. And I think, Dr. McCormick, we have you going first tonight. So I'm going to hand this over to you.
Super. Thank you. All right. I hope everything's coming across okay. I'm James McCormick. Thank you for that great introduction. I appreciate it. I run the colorectal cancer program at the Allegheny Health Network Cancer Institute and hold a professor of surgery appointment at Drexel University College of Medicine. Let's see if I can, oh, I'm having trouble. There it is. So I'm going to start with just a little bit of background information about colorectal cancer to get everyone on the same page about the importance. So colorectal cancer is the third leading cause of cancer in the United States in both men and women. In women, breast and lung cancer are more common, and in males, it's prostate and lung cancer. So really, if we talk about people who are at risk for colorectal cancer, it's everybody. Everybody raise your hand. If I ask you if you're at risk, raise your hand, no matter what your age is, no matter what your gender is, no matter what your race is, everyone's at risk for colorectal cancer. And that's why it's so important. Age, in fact, is the long-standing most important risk factor. The longer that you're on Earth, the more likely you are to develop colorectal cancer. We generally think of this as something that afflicts people greater than age 45, which is why we start screening at age 45. It affects males a little bit more than females. It's one of those rare cancers in that regard. It also affects apparently Black men with a greater propensity than any other group. There have been some shifting paradigms. I mentioned age as one of the greatest risk factors for the development of colorectal cancer. It turns out that in the last couple of decades, like other cancers, unfortunately, we've been seeing an increasing incidence in young people before screening age. So it's very important for everyone to be vigilant if they develop any symptoms of colorectal cancer. Go over some of those symptoms later. To that end, it's important. This little tidbit of information is very important. People born in the 1990s, these are our millennials, are 2 times higher risk of developing colorectal cancer than people who are born in the 1950s, and 4 times higher risk of developing rectal cancer. So we really need to keep an eye on this group of individuals, even though many of them are not, none of them are actually at screening age yet. So why does colorectal cancer happen? Certainly, we know that genetics plays a role. There are specific genetic syndromes that cause colorectal cancer. Age, as we talked about. Unfortunately, our lifestyle in Western society is one of the risk factors as well. Our high fat, high animal diet, excessive alcohol consumption, not enough fiber. Smoking certainly contributes to the formation of all cancers, and colon cancer is no exception to that. Lack of physical activity is associated with the development of colorectal cancer, and obesity, it increases people's risk by 2 times. Diabetes is also a risk factor, probably goes along with some of the other factors that we discussed. So we know that the Western diet contributes to the development of colorectal cancer. This was a good study that was done to prove that. Diets such as the Mediterranean diet, which is primarily fish and veggies, is one of the diets that is associated with a lower risk of developing colorectal cancer. So that's what we're recommending people try to consume. So symptoms of colorectal cancer, I did mention that I would tell you those earlier. I want everybody of any age, if they develop any of these symptoms, please to talk to your doctor about getting a colonoscopy and insist on doing so. Change in bowel habits, doesn't matter if it's in the quantity of your stools or the size of your stools. You should take note of that and get a colonoscopy. Bleeding, abdominal pain or bloating, these are not normal. Unexplained weight loss, decreased appetite, weakness or fatigue, or vomiting. All of these things can be symptoms of colorectal cancer and should not be ignored if they persist. So why does screening work? So screening is one of the greatest tools that we have for colorectal cancer in terms of prevention and catching and treatment at an early stage. So why does it work? Well, the reality is the development of colorectal cancer is slow. It takes years for a normal colon cell, pictured here on the left side of the screen, to become a cancer. It takes several years for all of these genetic abnormalities within cells to occur. And so we have an opportunity to intervene at either precancerous stages called polyps, or to intervene at a very early stage of the cancer and have a better result in terms of cure. So what are the options for screening? Colonoscopy is the gold standard, has been for decades. It allows us to remove the polyps and nip the process in the bud before the cancer even develops. Stool testing, including FIT testing or Cologuard testing. You see the commercials, I'm sure, of the little guy box walking around. That's stool testing. That's what that's advertising for. Those tests are very effective in detecting colon cancer, but they don't allow us to remove the polyps. So if any of these stool tests become positive, you must get a colonoscopy to follow up on that. There are a couple of X-ray studies that are done for individuals that cannot undergo colonoscopy, but those should be under the direction of your physician if those are appropriate for you. So colonoscopy, I mentioned, is the gold standard. Pictured here on the left is a picture of an inside of the colon lining, and this little red area there is the polyp. It's very small, and we can put a little lasso in through the colonoscopy and remove it, and lo and behold, the polyp is nipped in the bud before it can be develop into a cancer. It's both a diagnostic and therapeutic intervention with great success that has decreased the incidence of colorectal cancer in the country over the last few decades and allowed us to treat people at earlier stages. That's why we screen people for colon cancer, because it works. But screening only works if it gets done. There was a very strong initiative on a national stage initiated by the Obama administration called the 80 by 18 initiative. And we were trying to get 80% of people who are eligible for screening screened. We got to close to 80 and then we stalled out. For some reason, we can't seem to get over that threshold. So it was a good initiative. We got a lot of people screened, but we still have some work to do. Some people just don't get screened. So during COVID, obviously, a lot of things were shut down. What we learned was that the FIT testing, that stool testing that we talked about, was able to enhance our ability to get some people into the screening process. Even if it wasn't the gold standard screening process of colonoscopy, at least people were getting tested. And we also found that groups that are lower propensity to get tested with colonoscopy actually participated in the FIT study. So Black, Hispanic, and people of lower socioeconomic status for people who were having difficult getting screened. And now with the FIT test, the stool study, they were participating. So we added this to the list of things that people can use to get screened, and certainly we'll take it. If someone wants to get screened with a stool study, we will put them into the process with the stool study. It works. So the bottom line is that screening works because removing polyps nips the process in the bud, avoids the development of the cancer altogether, and then ultimately the colon resection never has to be done. So some things that you can do to minimize your risk, and I talked about them now. If you're worried about developing colorectal cancer, with, as I said, everybody should get screened. Don't ignore your symptoms. Try to eat a low-fat, high-fiber diet. Fish and veggies would be the best. Exercise regular. Maintain a healthy weight. Avoid alcohol in excess, and smoking should be avoided. So what if you have colon cancer? That's what the topic of this whole talk is about, and Dr. Bahary is going to add some things to what I have to say about. But what if you have colon cancer? What happens? Well, the fact is, if the colon cancer just affects your colon, we can get a 90% cure rate with surgery alone. That's pretty good. If it's moved into the lymph nodes, we're down to 2/3% cure rate, and we have to add other therapies such as chemotherapy into the mix to achieve that. If other organs are involved, that's when we have much more difficult time curing it. Again, don't ignore those symptoms. Get in early and get screened, and we get a better chance of curing you. When people come to me when they've been diagnosed with colon cancer, this is the goals that they have. Almost universally, everybody wants a safe cure. They don't want a permanent bag if they can avoid it, a colostomy bag or an ileostomy bag. They want to maintain their quality of life both through the treatment process and during their survivorship. And they would like a minimally invasive approach or to surgery or no surgery at all if possible. And so we all share those goals, and that's how we try to work with people to make that happen. So how do we treat it? Well, you can excise with the colonoscopy, as I discussed. Polypectomy can be done, or an early cancer can be removed that way. Or we have tools that we can deploy through the bottom, through the natural orifice, and develop the planes and remove the tumor without resecting a formal section of your bowel that way. So those are two options. Colon resection is probably the most common way that we treat these things, and it's very successful, like I said, in the early stages. And in some cases, we add chemotherapy and radiation treatment, and we'll talk about some of that in a minute. Minimally invasive surgery is the standard of care. When I was in training, we did these big old-fashioned incisions you see on the top. Nowadays, most people get the small incisions. Still a big operation on the inside, but it's a lot easier to recover from the one on the bottom. And we use it for all kinds of disease processes, and colon cancer is no different. Rectal cancer is no different. So the advantages of minimally invasive surgery is there's lower blood loss, less postoperative pain, hospital stays shorter, go to work sooner. You develop fewer adhesion or scar tissue. There's fewer medical complications. It's a benefit in the elderly folks in that they get to go home instead of to perhaps a rehab facility or a nursing home. And there's an immunologic benefit from having less trauma to your body that may actually impact your cancer outcome. So this is the standard of care for colorectal cancer. and should be done. And that's what we do here at Allegheny Health Network. So when we look at this, again, studying it, some of the things that we just talked about, definitely the cancer, the success in treating the cancer is the same with both the minimally invasive approach, the open approach, laparoscopic or robotic, but we do have lower blood loss, smaller wounds, fewer infections, and people recover from the surgery much quicker. This is a very important slide, in my opinion, because we can decrease people's morbidity when we do a better operation. And this is an example where we're able to do a better operation for people because of some of the technology that we use. What's being pushed down off that blood vessel right now are nerves, and those nerves provide people with the innervation to their genitals, and their urinary function is in part affected by whether or not those nerves are taken. We don't need to take the nerve to do the cancer operation. We just need to take the vessel, and we can see that nerve well and preserve it and actually improve people's urinary and sexual function by doing a better operation with minimally invasive surgery. This is a robotic approach. We have a 10 times three-dimensional image, and we can see exactly what we're doing and preserve those very important structures for people. We also have enhanced imaging capabilities. So the robot or the laparoscope is connected to a screen, and we can attach software to that. And here this is a picture of what we use to determine if the area that we're saving for the patient, we're making a reconnection here, an anastomosis between two ends of bowel. And we want to make sure that's well perfused. And if it's bright green and using this technology, we know it's well perfused, and we know that we're doing a safe connection in that particular situation. Very helpful. This is some additional augmented reality that we have that's artificial intelligence. This is not available in the US. This is currently being tested or being prepared for testing for FDA approval. It's software based, and it actually, the blue stuff is safe to cut. The green things that you see here are nerves that we're trying to preserve, and this is giving the surgeon some input about the tissues that they're looking at and helping them to preserve important structures and only cut what's necessary. This is actually me using this technology for the first and I think maybe only time in the United States on an operation. And again, you can see the blue is lighting up areas where I'm supposedly safe for me to cut. We're testing this now. We're in the works to develop a protocol to test this to get FDA approval. And this is one of the things that we're able to do because of our large volume center and our skilled surgeons. We're able to bring these technologies to the people of Western Pennsylvania, but really the people of the United States, sooner and first. This is great technology. We also have this SP robot, which is a single port robot. In some cases, we have to use multiple ports, but with this particular technology, we can make a small incision at the belly button and deploy a small, teeny little robot through that. And that allows us to work with multiple hands inside the belly through a single incision. This is me actually doing a case as part of a clinical trial that led to FDA approval for this device. And it has just recently been approved for this use in colon surgery. So we're very, again, happy to be at the front of the curve on that. So the robot allows the surgeon to sit at a console. We have a 3D image. It's magnified. The camera's stable. There's articulating instruments. I can direct my trainees like I would be directing a 16-year-old, teaching them to drive. I have pretty good control or complete control over when they stop and when they don't. And it really works very well to help us get that training part done without jeopardizing patient care. And integrating that imaging that I talked about really makes a difference and helps us as well. That's why I use it. It allows us to access these areas of the body that are difficult to access, improve precision and safety, and preserve structures that we want to preserve. The robot does not operate independently. It doesn't change the indications for surgery. It doesn't change the actual surgery that we do. And it doesn't make us wiser or better surgeons. It just helps us see better and make some decisions that might be easier to make because of the augmented reality. So to that end, what does it take to be a surgeon to do this? Well, it's a lot of training and a lot of experience. These guys are cute. They're going to be the future doctors, I'm sure. But until they get their proper training, we don't want them taking out people's colons or rectums for cancer. The surgeon themselves, the training that they and the amount of experience they have has a great impact on the patient's survival, the local recurrence rate, and sphincter preservation, which means avoiding that bag. So it's important to pick your surgeon wisely when you need to have surgery for this. So again, we'll go back to those goals. People want a safe cure. They want no permanent bag. They want to maintain their quality of life in minimally invasive surgery. So how do we do that? Well, we have a rectal cancer center of excellence that we developed over a decade ago. A group of us, a medical oncologist, radiation oncologist, myself, and some other our surgeons, radiologists, pathologists got together and said, hey, we can do a better job if we are every week organized together in a room and talk about all of our patients together. And so we started that over a decade ago. And turns out that the Commission on Cancer has decided to accredit programs for that, called the National Accreditation Program for Rectal Cancer Care. And we were one of the first places in the country to be able to achieve that because we were already doing it anyway. It's a multidisciplinary approach. We're all of our patients go into a database so that we can monitor our cancer outcomes. It's very important. We can then give ourselves feedback on how good of a job we're doing as compared to the rest of the country. We get pre-treatment staging is required. All patients must be talked about at the cancer conference before any treatment is initiated, so we don't have anybody going rogue on treatment plans. And our sphincter preservation rates are better, and proper surgical technique is monitored very closely through this program. So sphincter preservation, we talked about that, top priority for most patients. That means saving the anal sphincter so that you don't have a colostomy bag. We're able to do that with the use of chemotherapy, radiation therapy, expert surgeons, expert radiologists helping us to stage our patients properly, and expert pathologists telling us when we've taken out enough tissue. Organ preservation is a whole nother topic. Do we even have to do radical resection for some of these tumors? And the answer is no, hopefully not. We can do transanal surgery. We can do that colonoscopic removal, endoscopic mucosal resection. And in some cases, we don't have to do surgery at all. So here's an example of what we call transanal surgery. I'm able to deploy the robot through the natural orifice and remove the tumor without making an incision outside the patient's body at all. They don't even know I was there. And then we're able to close up the inside there with great dexterity, and in some cases cure the cancer by this technique alone. Very helpful to have this tool available to us. Watch and wait is a way that what we are calling when we don't do surgery. So these are people that get chemotherapy, radiation treatments, and they get a complete response. And we look at them with both the scope and MRI imaging, and we don't see any tumor. If that happens, it's safe to watch and not do surgery. It does require a skilled team. It requires proper imaging to be done, those expert radiologists I talked about before, and it requires an expert surgeon to make the clinical judgment that this is an appropriate case for this. It can be done safely, and we're able to not do surgery on about 20% of rectal cancer patients as a result of this. This is a relatively new phenomenon called watch and wait, even though it's been talked about for over a decade. Most centers in the country don't offer this. We certainly do. To that end, we are actually working on enhancing our ability to create that complete response, meaning that the tumor is completely gone. One of our radiation oncologists is working with a company to use enhanced magnetic resonance imaging, MRI, enhanced imaging from an MRI, to actually augment his ability to give additional radiotherapy safely to a tumor without affecting other tissues, and hopefully achieve a greater response, and again have more people not have to have surgery at all. I'm a surgeon, it's what I do for a living, but if we can avoid surgery, we're gonna help people better if they don't need it. So Dr. Kirichenko and I and the rest of our group are working on enrolling patients in a trial for this called the SMART TNT trial, in which patients will get this MRI enhanced radiation boost. Hopefully we'll be able to achieve, and we anticipate we'll be able to achieve, up to a 35 or 40% response rate instead of that 20% we talked about earlier. Just some fancy slides that he showed us about how that's going to happen. But you can see that there's excellent imaging from the MRI machine that shows us the response to therapy as the therapy goes on over the 5-week course. Dr. Kirchenko also does something called SBRT for metastases. So when we get into more advanced tumor stages, like liver disease, we're able to provide, again, safe radiation to hopefully create a situation where those liver metastases are destroyed without having necessarily to be removed. All of this is in conjunction with chemotherapy, but nevertheless, the mechanical removal or just destroying of that tumor is critically important to people's survival. If there's more advanced disease, we have excellent surgical oncologists who perform intraperitoneal chemotherapy. They can put intrahepatic balloon pumps, or I'm sorry, chemo pumps into the liver itself to deliver chemotherapy directly to the tumor. Again, we talked about the radiotherapy, lung resections, liver transplants, reoperative surgery. All of these things can be done. We have the expertise to do so. So what do we do at our Rectal Cancer Center of Excellence for all of our colorectal patients? They get evaluated and staged in a multidisciplinary setting. They get a tailored plan for that individual patient by a team of 20 or 30 or 40 providers that are in that room together for that one patient. They get one plan for that individual, tailored to their needs. They get an optimized cancer outcome, preserved organ in many cases, preserved function in many cases, sparing them that sphincter, avoiding that bag, and maintaining function and quality of life, both during the treatment process, minimizing the complications and the side effects, and when they're in their survivorship phases. This is done through this team approach, and we do it better than anybody. So I'm very happy to be part of this team and proud of it. That's all I have to say. Dr. Bahary's on the up next, and he's got a lot of additional things to talk about in terms of, systemic therapy. Thank you.
Well, thank you very much for Dr. McCormick. It's incredibly helpful to see that for everybody. I'm going to share my slides here. So I'm going to talk about medical advances. We've heard a lot about how at the multidisciplinary clinic and within the specialty colorectal clinics that we can integrate medical oncology, radiation oncology, incredibly cutting-edge surgical techniques. And what I'd like to in the remaining time is to give you just some highlights of new medical advances that we're having in colorectal cancer. They are making an incredible play into helping patients with these cancers. So the classical pathway is that you diagnose a cancer. It's amenable to surgery. And in rectal cancer, you get chemotherapy plus or minus radiation, and then surgery is performed. And that's kind of been the paradigm around. We've learned how to do it that way as opposed to giving it afterwards for a variety of reasons. But the chemotherapy can be quite toxic, and it's very general. In colon cancer, the opposite occurred. You did surgery and then chemotherapy if needed. If cancer is spread to the other organs, that's metastatic, it's spread. We give chemotherapy. Dr. McCormick talked about surgical ways and local interventions that we can do, or radiation therapy that we can do to control it at that time. But in those cases, it's not always curative. So what's new? And I'll subtitle it, One Size Does Not Fit All. So every time we go into many of these different things, even though within the medical oncology specialty, we're back at that weekly multidisciplinary clinic saying, this is the path we want to go to. What do the radiologists think? What do the surgeons think? What do the interventional radiologists, the radiation oncologists, all together, medical oncologists, what are going to do? So we're talking about some immune therapies. And this can be when the disease is spread in certain situations that we'll talk about, before surgery in some patients. Targeted therapies. You may remember in the 1990s into the 2000s, they sequenced the entire human genome. It took something on the order of $100 billion in 10 years. We can do a good portion of it for far less than that, in the thousands of dollars, in a couple of weeks. And we can look for kinks in the armor of the cancer to try to target. We've got a new thing, circulating tumor DNA, being able to see the DNA, which controls the tumor growth, but floating around in the blood, and then some novel trials that we'll talk about. So those are the 4 areas I'm going to focus on. So I'm going to use this disease. It's called hereditary non-polyposis colon cancer, or Lynch syndrome. Not really because I want to teach you all about it, but because it's caused by defective DNA repair. So your DNA is constantly being bombarded with things in the intestines, in the skin and radiation, and there is a ability for your body to detect it, that there's 2 strands of DNA, one does not match the other. It's called a mismatch repair, and it fixes it. And it's pretty amazing. But if it doesn't do that, you get this hereditary non-polyposis colon cancer. And you get multiple little non-polyposis, little adenomas. Usually by age 45, people can have, it's variable, colorectal cancer. It tends to be on the right side. But what's important to notice this is that you can get cancers of the endometrium, which are actually in excess of the colon cancer. So we have to know this. Ovaries, stomach, small bowels, kidneys, pancreas tumors. And so the question is, with this information, what can we do with it? So it turns out that deficient mismatch repair affects the immune system. So it turns out your immune system, both before and after birth, is learning what is you from what is foreign. And the idea of your immune system is that if you get a cold or a virus or something, it knows to attack it. It spares your normal organs. If we don't do that, we get autoimmune diseases like inflammatory bowel disease, rheumatoid arthritis. But it turns out that cancers, they start with your own cells. So unless something develops that's new, that the immune system can point to, it cannot effectively identify and attack the cancer. Otherwise, it would just be attacking all your normal tissues. And so if several changes turn up in a cancer, and we call these changes mutations, it's mutated, it's altered, some of these changes can be recognized by the immune system and will begin to attack it. And it turns out the more changes you have, the higher the number of mutations, the more vigorous and sustained that immune response is. However, you're saying, why doesn't the immune system just get rid of everything? Well, the immune system might be getting rid of certain cancers along the way. It's hard to prove that. But they also have developed, cancers are wily, and they've developed a system to quiet the immune response. And that is, they maintain a block on the immune system. It's called a checkpoint. And usually this is something that quiets the immune system. For instance, if you get an infection in the skin, you cut your skin, it grows, or it gets treated for a while and then stops. So we know when to turn it off. And the cancers have figured out how to turn off the immune system ahead of time. So it turns out that the efficacy of an immune therapy is directly related to the number of mutations. And if you noticed, this mismatch repair, like Lynch syndrome, has many, many more mutations. And it turns out that if you take a look at what happens in our system, we have a normal cell. It gets damaged by whatever means, hereditary, UV light, smoking, foods that go into the intestines, chronic inflammation. And something happens to turn it into a cancer. And if we find something that's new, the new thing is called a neo, a new antigen, the antigen is something the immune system sees, it turns on the immune system and says, and it can kill it. But immune checkpoints are designed to suppress the immune system, as we talked about. Cancer cells can block this. And so it turned out that in the 2010s, in 2012 and 2017, 2 different groups found checkpoint inhibitors. So these are checkpoint blockades that can inhibit the blockade. And so checkpoint blockade can be overcome by these checkpoint inhibitors. There's many of them. You probably see Keytruda, pembrolizumab, and Opdivo, nivolumab, being advertised on TV. And it works amazingly well for cancers with lots of changes in the cancer, such as in melanoma. But it turns out that in the subset of colon cancers that also have a similar thing with lots of changes in the DNA, you can give this immune therapy, which is far less toxic and has long-term survival and even cures. So if you take here, this was a study that was done normal colon cancers versus those like Lynch syndrome. And here, this is better. That means that the cancer is getting smaller, and you can see this is being controlled for years, whereas usually in metastatic cancer, that is the average survival. But these patients are all living a very long time. How about the duration of response? Well, if it worked, what came out is it better than chemotherapy? So this was a study that was done looking at chemotherapy for those patients who had mismatch repair tumors and either an immune therapy, a checkpoint inhibitor, Keytruda, pembrolizumab, versus chemotherapy. And if you take a look, this is the chemotherapy. And actually, if you continue it, people, unfortunately, by years 4 and 5, very few people are alive. And here, about 70% of the people appear to be cured with the immune therapy. So now if you come in with one of these kinds of cancers, whether it be hereditary or not, actually what will happen is that you'll get an immune treatment. And so this is literally hot off the press. It was at a meeting that I went to 6 weeks ago, and it was some initial results of looking if one immune therapy is good, how about two? So this is the survival for one, and here's the survival for two. So this is quickly becoming, using multiple immune checkpoint inhibitors, the standard of care for these types of cancers. And so it's really important to try to search for this. And so here's just to give you a picture. This is a 58-year-old male came with me Lynch syndrome. And he had been told that his likely would live only like 4 to 6 months, that this tumor, looking in here is this thing I highlighted in yellow, and there was really not much. He received all chemotherapy, and we put him on an immune therapy, and after 3 months, it's nearly completely gone. And this was 5 years ago. And he appears to be cured from this. And the last time I saw him a few months ago, he brought in pictures of all of his grandchildren and a great-grandchild born since he was diagnosed and treated with this. So it's truly paradigm changing. So can we move it to earlier stages of cancer? Remember, taking things out earlier is better, giving chemotherapy or immune therapy prior. So this is in rectal cancer and was truly paradigm shifting as well. The idea is usually if we had some sort of rectal cancer, so we're worried about having to remove the rectum and perhaps the anus in those, but not always, that we'd give chemotherapy and radiation in some combination, and often you would go on to surgery. If you had a complete response, we could watch you, as Dr. McCormick said. However, what we did here was give in patients who are about 5% of patients who have rectal cancer, and they tend to be young patients. We gave them a different immune therapy, and they got it for about 4 months. And then it turned out the plan was if they still had disease, they'd go on to chemo and radiation therapy and possibly surgery. And it turned out that amongst the first 20 patients, every single person had a complete response and no one needed surgery. And that's been extended now into the hundreds. And of course, when you start getting to those numbers, there's some people who will not make it there. But nearly everybody, if you've got this subtype of rectal cancer, will actually be able to avoid chemotherapy and be able to avoid surgery. So immune therapies are exciting. They're a wonderful new direction. So far, it's limited tumors that are readily visible to the immune system. It's about 15% of colons, 5% of rectal cancers, and we think of this as potentially curative. So one of the things that we've done in our multidisciplinary clinic is no one gets discussed with these cancers without a complete evaluation for the many different reasons that you might be able to respond to immune therapy. It is now, in the last year or so, 2 years, become the standard of care as part of a workup. So we talked about immune therapies. How about targeting non-immune therapies? Can we find a chink in the armor? One of the first ways was doing this is looking at blood vessels. So there is a drug called bevacizumab, and it can actually transform blood vessels. It can make them a little bit normal so chemotherapy can get in there because they're abnormal in the cancer, and they can also starve a cancer of blood. And so that's one, we can target blood vessels. The other thing that we can do is it turns out that if this is the surface of a cancer cell right here in this kind of bluish gray, there are things that are called receptors. They sit on the surface. And what they are is, like, for instance, this is epidermal growth factor receptor. You cut yourself, this gets turned on to say, hell, skin keep growing. And it's also turned on and an active in cancers. And so the idea is if you could block it, and there's a couple of different blocking agents, or this one's called HER2. It's very commonly tested in breast cancer. You may have heard of it from then. There's a drug called Herceptin. These are antibodies. They can block the activity, and they can actually then go on to treat the cancer, and you can get remarkable responses. And I'm just showing you this little cartoon to say that if these things that are like this turns on that, this turns on that, if this is turned on, blocking what's above it won't work. It's like as if I put a broomstick on the throttle and but then cut your brake line. It's going to grow completely. You're not going to be able to stop it. So we check for these types of tumors, these type of changes in the tumor. And that's called next generation sequencing. So this is what I alluded to, which took years and millions and billions of dollars. And now we can do it in weeks. And what it does is it allows us to look at different genes. Genes are the units of growth, and we can see if there's a change. So there is a patient who came to me with colon cancer, right? We wanted to use this EGFR. We got this sequencing. It came back that unfortunately he has a change in this gene called KRAS that changes an amino acid from one to another. It's called G12C. And though we couldn't give him an epidermal growth factor receptor, it turns out that we've learned to drug this. And so actually, if you have this change, we can actually give you a small molecule. He got one of these in the yellow. The other ones are still being tested. And he had an incredible and sustained response. So what it tells you is that by doing next generation sequencing, and this type of sequencing that we do gets done on everybody, along with all the immune therapies lookings that we do for every patient who walks into our multidisciplinary clinic. Because if we can find this Achilles heel, we can offer people treatment for it. Okay. So it turns out that if you look things, you can take a step back. Isn't this cool? High science, basic science being translated into the clinic. And sometimes you just ask, well, if you have something like an epidermal growth factor receptor inhibitor, one with cetuximab in this, and if you take a look at another one like bevacizumab, though it's not shown in this cartoon, but they looked at both, and you ask the question, who responds? Well, it turns out if your cancer is on the left side of the colon, you respond to the EGFR inhibitor. We're not certain quite why, but we're trying to understand this. And on the right side, you don't. But on the right side, you actually respond much better to that inhibitor of the blood vessels. So what we've learned from this is we've integrated next generation DNA sequencing into the evaluation of all of our patients. And if you look at the bottom one of these little bullets, there's at least 14 targeted agents approved by the FDA, but there's another dozen and probably 3 or 4 more coming online that have clinical data to support their use. So are these the majority of people? Not yet, but there are a significant proportion of our patients might have something that we can offer other than historical chemotherapy and that have better outcomes. And we also learned from these studies that certain targeted agents, like the blood vessel inhibitor, appears to do better when the colon cancer is on the right side, and other ones like EGFR inhibitors, epidermal growth factor inhibitors, only work when that RAS gene is normal and they're left-sided. So we won't use them in any other place. Obviously, it's easy for us to figure out if the cancer is on the left or the right side because of all the testing we do, but then we have to integrate everything into developing a comprehensive plan for that patient. So what's next? Talked about immune therapy, some other targeted therapies, circulating tumor DNA. So it turns out that there is, when the cancer is in the colon, as you see on this left side, you can actually shed that DNA, shed tumor cells, which are degraded, and you can pick up the DNA in the blood. So in this test, what they did was find a unique signature for the tumor. So they take the tumor, they identify 16 different things that are found in the tumor that might be found in the blood. And what they do is develop an assay. It's called circulating tumor DNA. It's an assay just specific for that patient. And what it does is you can see there's a lot of that circulating tumor DNA in the right after surgery that it comes down really quickly because it's being cleared by the blood. And if it's not cleared, that's a problem. And so, why do we want to know this? What might we be able to use it for? We might be able to pick up early recurrences. But there's an actually more interesting to me and more important to patients reason to try to use these assays, these new tests. And then if you take a look, if you give chemotherapy to certain types of colon cancers, this is the one with the and versus just observation, there's about a 5 to 10% difference. So about 10% of people will be living with the chemotherapy that we give you for 3 months after, as opposed to if we did nothing more. Now, if it's a more advanced cancer with more lymph nodes, that might be 30 or 40%. But whatever that number is, everything above that line, we are undertreating. Those people recur anyway, despite it. And all these people never needed to get treated, and everything comes with side effects or so. And so when you're looking at this, this is how might we decide who to treat and who not? And that's that little difference. Those are the people we help. We don't want to over or under treat anybody. How can we move forward? Well, this colon cancer assay looking at ctDNA that's informed by the tumor, it was looked at. And so it turns out if a patient has surgery with Dr. McCormick and comes to me and they don't have any ctDNA, no circulating tumor DNA, they have a 90-95% chance of actually being cured. And many of the studies are suggesting that those people actually don't benefit from chemotherapy. The question is, we might be able to not give chemotherapy to those people. And then this other line is if you started out positive, but then became negative, you did just as well. Though there's a difference in here, it's not statistically significant. Whereas if you're positive, or you are negative and then became positive, you don't do as well. And so these are people that probably need more early observation, perhaps more surgery, back to the multidisciplinary clinic. The earlier we get them in there, the better, right? Because the tumor may be smaller, to use radiation, to use interventional radiology techniques. Perhaps there's something that Dr. McCormick and his colleagues can remove and try to cure somebody or at least prolong their life with a better quality of life. So how can we use this? This is a patient of Dr. McCormick's and I, whom we actually did surgery on. We're following this test. And if you notice here, about a year ago, it went actually, just the way this got cut off, it was at 0 for a while, a couple of years. It went up really high very quickly. And so we were able to decide, okay, we're going to intervene and treat him. And he had already had one tumor removed, and it looked, and he responded very well as we followed him. All of that tumor blood, the DNA of the tumor in the blood disappeared, and he became completely negative. And Dr. McCormick took them to surgery, and all the tumor that was in that area, it was still a little mass, was completely dead. And we think that we have cured him. And hopefully time will tell as well. But it shows how we can begin to use this. Now, we had started off by saying one of the great things about this is that we might be able to decide who to treat or not. So this is a unique trial called the Circulate trial. NRG was one of the things at Allegheny Hospital, the NSABP, that's what the N stands for, started here and did some incredible studies with colon cancer and breast cancer over the last many decades. But they've now merged with other groups. They're called NRG. And what this is you take cancers that have lymph nodes or not, and then we register them and we check to see if they have ctDNA. If they're negative, they actually get randomized to getting chemotherapy or just monitoring. And the idea is to say it's not enough just to look in retrospect because the arms could be imbalanced, but can we prove now that if you have no ctDNA, could we not treat you? And so we're enrolling patients in this trial pretty well, and we're very excited to see this to completion. Now, cohort B are people who have like stage 3 cancers or have positive ctDNA. and they get regular chemotherapy or intensification of chemotherapy. So they get another drug added. This is 3 drugs as opposed to 2 drugs. And so if you have low risk disease, you might be monitored. If you get high risk disease, you get standard chemo or intensified chemo. And the idea of this, and hopefully it will prove it, because this is being done nationwide and a similar studies being done in Europe, we'll be able to use a blood test to be able to decide whether you need chemotherapy after your surgery. So this is just to give you an idea. At our multi-clinic clinic, there's lots of different trials for colon cancer. Many of these, like this is the one we just talked about. These are other trials that are available for different kinds of cancer. This is an interventional surgical trial. And we're going to be having a number of liver-directed trials as well, as Dr. McCormick alluded to. So in rectal cancer, we also have, here's a trial for prior chemotherapy to surgical resection. So these people can't use immune therapy. If we use 2 drugs versus 3 drugs, can we improve your outcome? So let's look at a different way. Remember that last one was you take the tumor, you look in the blood and you match them. This is just looking in the blood for DNA. And so you can identify targets without tissue. Perhaps it's too small. We can't find enough cancer in the tissue that was removed, and we want to know. We might be able to develop assays for early detection of cancer in the blood. And sometimes what happens is that people's tumors respond, then start progressing. And with this type of test, I can find something in the blood that makes it resistant. And I can say, I now want to use a different type of treatment to put that person back in remission. So what are we doing that's unique here at AHN? But when Dr. David Bartlett came on as the Cancer Center Director in the 2000-2001 timeframe, we created this program called Moonshot. And what we're asking is every patient with every kind of cancer who comes through the door to give a little bit of blood as they start their therapies, pre-surgery, post-surgery, if they're getting treatments before, during, and after treatments. And we're looking at DNA, proteins, and cancer markers in it. And we're getting monthly blood draws, and then you kind of look at them with less frequency as time goes on. We correlate it with the medical record, and we're hoping that we can identify markers of how to treat patients just from the blood. So one of the other things that we're doing is looking at different biological therapies. And you've probably heard about these things, CAR Ts and TIL cells, or you may not have. What we do is we take white cells out of a patient and you either add something back to them after you've excised it, in this case, and you give it back that can help fight the cancer, or you isolate white cells that can fight the cancer better and give them back to the patient. And these have been done very well on blood malignancies, and we've now got a very large trials going on in the solid tumors, not just colon cancer, breast cancer, and others. So this just goes like in the immune system. What are we doing to try to help everybody else who doesn't have that special thing? There are cancer vaccine trials getting underway. Oncolytic virus therapies is a virus that might be able to help people with cancers. Immune checkpoint inhibitors. This is those TILs and CAR Ts and other types of immune therapies. And can we integrate these things into trying to help patients? And this is all being done in a brand new cellular therapies facility that's centered at West Penn Hospital. So with that, I thank everybody for listening, and we're glad to entertain any questions you may have.
I see a question. Let's see. For an individual who has had a successful kidney transplant post 16 years, what are the chances of chemo and radiation treatment being successful while still on immunosuppression drugs? We don't want to risk rejection.
I can take that if you'd like.
Sure.
Yeah, go ahead, Nathan.
Yeah. So the longer one has had a transplanted organ, it's never perfect. Okay. The less likely it is to be rejected. And if your transplant team follows you closely, if you're still on immunosuppression, they can often tell us if something is not going right and change the immunosuppression. So there's a very good chance that you can get chemotherapy and radiation. This might be for rectal cancer where we use that kind of treatment, perhaps. and it can be successful even while on the immunosuppression drugs. Now, we do think that immunosuppression allows cancers to grow a little bit quicker, but on the other hand, you don't want to come off of it and risk rejection, as you said. But this is where we go beyond our own multidisciplinary clinic. We'll bring in the transplant doctors, the kidney doctors. They'll show up, they'll give us their opinions, and they'll tell us with their expertise, how do we avoid this? Because it's an outcome we don't want to have happen.
Okay.
The thing too, we certainly operate on people who are transplanted. We are, AHN's a huge transplant center. We have a lot of transplant patients, so we do operations safely on those patients, again, in conjunction with those transplant teams. And remember what we talked about when we talked about organ preservation and avoiding surgery. Our best case scenario is 20 or 30% of those people have a complete response and can avoid surgery. So we still have to keep that as maybe an option in some cases.
Let's see, any other questions?
There is a question about anal cancer I saw that come through. There's a second question about, sorry, if you've had chemo and radiation for anal cancer within the last year, post-treatment, how often should you have follow-up scans for recurrence? Do you want me or would you like to take that, Dr. McCormick?
Well, so that's a little different topic, but it's not really related to colon cancer or rectal cancer. Anal cancer is a separate kind of cancer, which responds really well to chemo and radiotherapy and very rarely needs surgery. But we do surgery occasionally if it does come back or it doesn't respond to the chemo radiotherapy. We follow these people depending on how far out you are from your treatment. We follow them every few months for the first couple of years. And then after that, it's every year or so. And then after about 5 or 6 years, you don't really have to be checked again. The greatest risk for it coming back is in that first 2 years. So if your tumor is completely gone 3 or 6 months after your chemoradiotherapy and you get past that 2-year mark, that's a pretty good mark. Ring that, be excited about that, because most of them are going to come back in that first 2 years. So that's when we need to be the most vigilant, is in that first 2 years after treatment.
I think we have time for one more question.
Okay.
Do you want to read it, Dr. Bahary? Do you want
Yeah,
me
I think I'm going to have to take it too. For the dual immunotherapy trials, how many cycles for dual therapy are patients experiencing increased incidence of adverse effects associated with immunotherapy, similar ipi-nivo for melanoma? So it's significantly less. The risk of severe diarrhea and others, what we call grade 3 serious adverse events with melanoma, is on the order of 30 or 40% because it uses a significantly higher dose of ipilimumab, Yervoy. So this uses a much lower dose. It's limited to 4 doses. And the nivolumab goes on as long as people are having a response. The duration of the nivolumab of the single agent is great idea. Most people are stopping at 2 years if you've had a complete response and we think it's cured, but probably a year will be sufficient. But again, it's going to have to be individualized to how quickly your tumor goes away. Are you following with a tumor marker, ctDNA, something like that? So.
There's another question here. I've been cancer free since 2019. What are my chances now? So that does depend on if it was colon or rectal cancer. But if you're 6 years out from colon cancer and you've seen your doctors and you've had your checkups and there's no evidence of disease, then we consider you to be cured typically, depending on your initial stage, as long as it wasn't stage 4. Then your chances are very small that cancer would come back. But remember, your colon's proven itself to be a bad actor. It already made one cancer. So those colonoscopies have to be done much more frequently on you to make sure you don't develop a new cancer. So keep up with those.
I'll make one more plug. If you're cancer-free, you should stop smoking before ever. It's the worst thing you can do, but it's an incredible risk factor for cancer coming back. And it appears that people who change their diet, as Dr. McCormick had mentioned, and or exercise more regularly have a reduced risk of cancer recurrence. So all those things that would make your intestine happy, makes your cardiologist happy, and your PCP happy, and your family happy, and go and do it.
Dr. McCormick, there's just one question here, and I think that we can sum this up. 31-year-old male recently lost father to colon cancer, not sure what kind. What kinds of tests? I think that means to be proactive. I think that's the question. Can you answer that?
Well, I'm assuming that the 31-year-old is asking the question and the 31-year-old didn't have the cancer. So if the 31-year-old had the cancer, then we need to get some genetic testing done because that's a very young age to develop cancer, and there could be a genetic problem that needs to be looked at specifically. So if it's a 31-year-old asking the question about their father, who may be 50 or 55 or 60, then you need to get a colonoscopy 10 years prior to his diagnosis when he was diagnosed. So if he was diagnosed at 50, you would get your colonoscopy at 40. If his cancer was diagnosed at 60, then you would be in the normal range of perhaps 45 years old. But again, don't ignore any symptoms. If you have bleeding, problems with your bowels, changes in your bowels, get it when you're 30. It doesn't matter what age you are. If your father was very young or had multiple cancers, or there was multiple people in your family who had cancer, you may want to see if you can get genetic testing done to determine if that was a familial cancer. But if he was in the normal age range for colon cancer and there's none of those other factors, then typically, 45 is the standard age for screening, and that would be when you would start.
Okay. Sorry, I just muted myself. So it looks like we have answered all the questions. We'd like to thank everybody for attending tonight's Ahead of Cancer lecture series. As a reminder, tonight's lecture has been recorded. And if you're interested in rewatching it, it will be uploaded to our AHN YouTube channel within the next couple of weeks, probably the next week or so. On that channel, you will also find videos of our previous lecture series. Thank you, Drs. McCormick and Dr. Bahary, for an excellent presentations tonight. And thank you to all who attended our lecture. On behalf of the Allegheny Health Network Cancer Institute, thank you and have a great evening.